treated which patient, which lipid should be attacked, and which drug should be used. Who to treatment? All our chronic kidney patients who are hyperlipidemic, and this is proved by animal studies and somewhat by the human studies. I'll give you two examples on the human studies, just in short. SHARP study, which is study of the heart and renal protection. It was conducted on 9,720 CKD patients. 3,000 were on hemodialysis, 6,000 were not, and a group was on simvastatin and ezetimibe, and a group was placebo who did not receive treatment. The results were very impressive, 17% reduction in relative risk, but obviously there is a flaw in the plan of the study because they used two drugs against placebo. The second drug, ezetimibe, is a drug that inhibits the absorption of cholesterol from the intestines, which looks an attractive and logical combination for the patient is to use both, but this was a flaw in this study. The second study is the CARE study, which is a cholesterol and recurrent events. They chose patients with normal creatinine, but low NDRD, and they gave them parvastatin, and they followed them for some time, followed the renal function. The results showed that the statins might reduce progression to chronic kidney disease. So who to treat? Of course, the chronic kidney disease patient and transplant patients are at the highest risk of cardiovascular morbidity and mortality. Diabetes mellitus itself is a state of accelerated atherosclerosis. Lipid-lowering drugs, according to Ramuzzi in 1997, have a major role in retardation of the macrovascular disease. This is boldly accepted. Whether they alone have an effect on the microvascular disease in the kidney is questionable. They have to be with other factors. Which lipid is to be attacked? Definitely all of them, but definitely the low-density lipoprotein. If we treat, we have to follow the guidelines, and we have guidelines. The National Kidney Foundation KDOQI guidelines are very clear. Number one is that chronic kidney disease and transplant patients are at the highest risk. Evaluation of dyslipidemia after we treat is at the beginning, at the presentation when we see the first time the patient, after change in status, which is the adjustment of his lipids, and then annually. But obviously, this is in a chronic kidney disease patient, not in a transplant. In a transplant patient, we have to measure the lipids more frequent because of the drug situation. What is the level when we introduce the statins? When the LDL is from 100 to 129 milligram per deciliter, and a very optimal level would be 70 milligram per deciliter. What is the initial drug to use? It's the statin. Are we allowed to use fibrates as a combination? Yes, even in stage 5 CKD, in two conditions. If the triglyceride level exceeds 500 milligram per deciliter, or if it is above 200 and the patient cannot tolerate the statins. How he cannot tolerate the statins, you all know this, is by breaking his muscles, causing muscle pains, elevation of the CPK, or elevation of the liver enzyme, which is very common in our patients due to the HCV status of our patients. And we should measure more frequently in the transplant patients. Thank you.
Thank you, Professor Bilal, for this presentation. And I guess that there is time for a few questions. Okay, Turhan. Professor Hana Hafiz.
Thank you, Professor Dawlat, for this very elegant presentation. Regarding, our dialysis patients have a sort of protein energy malnutrition and maybe have some reversed epidemiology that when we lower the cholesterol, yes, the levels of the risks, including the mortality risk, may increase.
That's
so
right.
I am doubting the 1/3 of the patient in the SHARP trial were on hemodialysis. they got the same 17% improvement like the patient who were not on hemodialysis, or there is a difference between the two groups?
It's advisable, these rules, actually, what I mentioned, do not, we cannot have them with hemodialysis patients. We have a reverse relation here, that the cholesterol level is related to the mortality. So we should never be so enthusiastic to adjust cholesterol level in hemodialysis patients, because when it's lower, the mortality increases. So maybe I missed to mention this, that we do not follow these rules in hemodialysis patients. I think the results were global. The results of the 17% reduction in mortality, reduction in the risk ratio were global.
The second comment regarding the importance of cholesterol versus the other factors in the vascular calcification. In the pre-dialysis stage, do you think the cholesterol is more important, or the excess calcium phosphate deposition that we
for dialysis patients?
No, before dialysis, even in our Egyptian population, for which we give we don't follow carefully the calcium phosphate and the PTH, and we leave our patient overloaded with calcium phosphate. Which one is more important, in your opinion, in our CKD patients?
What I get from your question, which is more urgent to control in a dialysis patient, the cholesterol or the calcium?
Yes, I mean the metabolic bone disease in general, not the calcium specific.
In a dialysis patient, in a dialysis patient, cholesterol is very critical to control. We should not enthusiastically control cholesterol. I think calcium for calcification is more important in a dialysis patient because of the mortality. Not because that cholesterol doesn't take part in the calcification, in the plaque, it takes part, plus the calcium, but the mortality increases if we reduce the cholesterol.
Okay. Any other questions? I just have a few comments, if you allow me, regarding the meta-analysis that was published last year about the use of statin in kidney in general. And this meta-analysis was published in the Cochrane reviewer group, by Cochrane reviewer groups. And this meta-analysis included 80 trials, including 50,000 patients. And the conclusion is use of statin is beneficial for CKD regarding the cardiovascular mortality and all mortalities. And it is not beneficial at all in dialysis, no difference if you use it or not for the mortality. And in transplantation, it is doubted. Another point that I want to refer to the Professor Hani Hafiz, that the lipids in dialysis is not the lipids of the general population. HDL in dialysis is not the HDL that we know. It is deformed of abnormal structure and atherogenic in dialysis patients.
Yes, that's right.
This is the point. But regarding using statin to retard the progression of CKD, a lot of debate, as you mentioned. So the evidence is to decrease mortality and the cardiovascular mortality, and the evidence to protect the kidney, I think it is very, very low if it's present. And the diabetic potential of statin that was elaborated from the postmenopausal ladies gives some doubts and the shadows about the beneficial effects of statin.
Okay.
Thanks so much.
I have just one comment for the Egyptian Fellowship. Thank you for congratulating me, but this is a teamwork. I'm just heading the technical part of the accreditation, but Professor Hani Hafiz is the Secretary General.
Sure, the board, all the board.
Probably I'll lose my job today because you accredit me today. He's the major.
But if you allow me, I want to refer to the statement of the professor of Ireland, professor who attended the accreditation. He mentioned with his statement that there is a miracle that occurred within 2 years. And I want to congratulate as well the National Institute for the magnificent and the fantastic preparation for the exam.
Yes, thank you very much. Thank you.
Next speaker, Professor Hisham Safouh. He is a professor of pediatrics and pediatric nephrology, Cairo University, and he is the president of Pan-Arab Pediatric Nephrology Association, PAPNA. He's going to present CKD in Egyptian children.
تموت من هنا. اوكي. من هنا احسن. Okay. بسم الله الرحمن الرحيم. It's actually a great honor for me to be here today and speak to such a very big group of distinguished professors of nephrology. I'm always overwhelmed when I stand in front of such a big group, and because I gained a lot from attending these meetings from our adult colleagues. I think there are very few things which we pediatric nephrologists might have more experience with compared to adult nephrologists, and maybe minimal change nephrotic syndrome, and I'm sure hereditary nephropathies. So it's always a great pleasure to be here. I thank Professor Dr. Tariq Elbaz and Professor Hussein Shaheen for the invitation. I'm not going to give you any advanced scientific lecture like the ones we've just seen before. And I'm not interested in boring you with details of statistics. And actually, the correct title of this talk was The Causes of CKD in Egyptian Children. And the reason I thought that it might be suitable to do this work and to present this talk is the fact that we still, as you will see, as you will see along the talk, we are lacking a lot of information about cause of CKD in Egypt, both from children and in adults as well. And this is just some data in relation to chronic kidney disease in children worldwide. And this is data from the 2008 Naprotix data. And as you can see, the estimated instance of renal replacement therapy or end-stage renal disease in children, in the child population between the age of 0 to 19 years is about 9 per million, and the prevalence is between 18 to 100 per million of the same age-related population. Of course, depending on the different sources in different countries that report the data. And I'm sure you all know, and we in pediatrics know very well, that chronic kidney disease is a very devastating illness, and the mortality rate is 30 to 150 times that of the general pediatric population. And when a patient is diagnosed with end-stage renal disease, actually the remaining lifetime may only be up to 20 years from the stage of end-stage renal disease. And we know, of course, how more specific aspects of chronic kidney disease in children include the severe affection of growth, especially in developing countries. We have a very big problem in maintaining the growth potential of these children who have chronic kidney disease of any stage. And in addition, there are massive psychological issues and difficulties to deal with these patients. Nowadays, of course, there has been a lot of improvement in the survival of patients with chronic kidney disease, especially along the past 30 years. And as we've just heard in the past lecture, many more patients now die of cardiovascular complications and infectious complications rather than from the actual renal failure. And just to show some data from Egypt, this is unfortunately what we get when we try to search, for example, PubMed or Medline, and we put the keywords CKD and causes and Egypt. Every time I do the search, I get just anecdotal data on the causes of chronic kidney disease. There are no published data on chronic kidney disease that are easy to find and straightforward. And it's very embarrassing when we go to a meeting, an international meeting or any other meeting, and data is presented from much smaller countries and smaller countries in population and smaller countries in world impact than Egypt. And till today, we cannot find published data on CKD. And this is what prompted us in our unit to try to look for at least the cause of CKD in Egypt and to try to do a collaboration between more than one university. And we have proven that cooperation can lead to success in collecting a good amount of data that we hope will improve and increase. As you can see, it's easy to find data published from countries like Saudi Arabia, from Kuwait, from Jordan, from Turkey, and from Iran. But we cannot find any significant data when we do a search on cause of CKD in Egypt. We just find, as I said, few research papers that give causes of CKD in relation to the specific topic that they were researching, but no collective data. And as you can see here, in the incidence and prevalence of end-stage renal disease from the US RDS data in 2005 and similar data from in 2008, we hardly find the mention of any developing country from our part of the world included. And just to compare between 2005 and 2008, Turkey now is clearly reporting adequate data. This is the only developing country in the Middle East that I could find that has been added to these characteristic figures that we see in reported data. So I just want to ask the question, why are epidemiologic studies important? Of course, there are distinct geographic differences between different places and different countries that explain the differences between chronic kidney disease in the population. There are environmental differences, racial differences, genetic differences, and cultural differences, including, for example, consanguinity and the effect of consanguinity on disease. In developed countries, there's a general impression that congenital disorders like congenital anomalies of the kidney and the urinary tract and hereditary nephropathies constitute up to 2/3 of the causes of chronic kidney disease in children, and other causes may constitute about 1/3. Whereas in developing countries, there's a general impression that acquired causes may predominate. This is the general impression. And there is a lot of difference between adult data and pediatric data. First of all, there are extensive reports and a lot of data from the adult population. On the other hand, limited information and limited data from children and infants worldwide, and especially from our part of the world. In addition, the causes of chronic kidney disease are very different in children from those in adults. And actually, most probably that end-stage renal disease or CKD stage 5 really represents the tip of an iceberg. And most of the data we find in the literature is related to end-stage renal disease and terminal stages of chronic kidney disease. And there is very little info in the literature on the other stages of chronic kidney disease. This was in part due to inaccurate definitions on this, about the stages and different parameters of definition of chronic kidney disease. And it has improved after the correct classification of the stages of CKD into stage 1, 2, 3, and 4, and 5. It's expected that this will improve the epidemiologic surveys that are being done. And definitely, I think we all agree that knowledge of CKD epidemiology will lead to much better improved primary prevention, early detection of causes of chronic kidney disease, and will assist in directing units to the aggressive management of these cases. Now, just a few slides from our data, and I have no intention to bore you with dry statistics, but just to show you that we were able to collect data from 11 universities in Egypt, and I'm very grateful for all the colleagues, the pediatric nephrologist colleagues in these 11 universities who have contributed data. And from Cairo, you can see we have been able to collect data from Cairo University and Shams University, Al-Azhar. We took data from the Azii University, Mansoura, Banha, Alexandria, Tanta, Al-Munufiyya, and from Upper Egypt, we collected data from Suhag and Asyut, a total of 11 universities. And actually, the criteria, this study has many defects, and it's only a start for what we hope will be further prospective studies and further correct collection of data, and to try to start a permanent pediatric CKD registry. And as you see, it was a retrospective file review study, and it included all patients with CKD of any etiology who had an age between 1 year and 19 years at the time of diagnosis of CKD. Exclusion criteria included all patients with acute kidney disease of any etiology. And this is the definition we used for the staging of CKD. This is found, I'm sure all of you are familiar with that. There is no need to waste time on the different 5 stages of CKD, and we tried to classify the cases into these 5 stages. And we used the Schwartz formula for calculating GFR, and Schwartz formula is an estimate of the GFR by dividing the height multiplied by a constant K over the serum creatinine of the patient to determine the GFR and to classify the patient into the CKD stage. Now, as you can see, we were able to collect data from 945 patients, And because this was a retrospective study, and I said there were some defects, maybe there were some errors in collecting all the files from a particular university